All right, welcome. Today we're doing a high-yield tour of breast anatomy. We're going to focus on the absolute must-know facts, the stuff that comes up again and again, both on your exams and in your day-to-day clinical practice. So let's dive right in.
So let's start with this question. What secrets are really hiding in breast anatomy? I mean, what are the things that every single clinician really ought to know? We're going to go beyond just the textbook diagrams to uncover what's clinically relevant and, of course, those classic exam curveballs.
Okay, here's our game plan. First, we'll take a quick tour of the breast, starting from the outside and working our way in. Then, we're going to zero in on where cancer really likes to hide. After that, we'll map out the lymphatic superhighway, cancer's escape route. And finally, we'll cover some classic anatomical mimics so you don't get tricked. First up, our tour of the breast. We're going to start right at the surface, looking at the external structures and the signs that can tip you off that something might be going on underneath. Let's kick things off with a really crucial distinction. You see, chronic nipple inversion, something a patient has had for years and years, is often just a totally normal anatomical variant, nothing to worry about. But if that inversion is new, that is a huge red flag. It should immediately make you wonder if there's some underlying cancer that's pulling and tethering that tissue inward. This is a perfect example of why getting a good patient history is just everything. Now let's meet the key players inside the breast. First, you've got Cooper's ligaments. Think of these as the thin, fibrous support wires that hold everything up. Then we have the lobules. These are the little flower-shaped factories that actually produce the milk. That milk then has to get to the nipple, and it travels through this whole tree-like network of ducts. And pay close attention to this one. Right underneath the nipple, there's the lactiferous sinus. It's just a normal, slightly widened part of the duct. It's super important to remember that this is not a mass. All right, moving on to section 2. Now that we've got the basics down, let's dive deeper into that internal architecture and really pinpoint the specific spots where cancer is most likely to be hiding. And this brings us to probably the single most important functional unit in the breast when it comes to cancer, the TDLU. That stands for the terminal duct lobular unit. It's exactly what it sounds like. It's that junction where the terminal duct meets the lobule. So why do we care so much? Because this is ground zero. It's the origin point for the vast majority of breast cancers. So where are the primary danger zones we need to keep an eye on? Well, statistically, the upper outer quadrant is number 1. And that's really just because it has the most fibroglandular tissue. But cancer can be sneaky. It can hide in less obvious places. So you have to be really suspicious of any density where you just don't expect to see it. Specifically, that means the medial and inferior parts of the breast, and in that retroglandular space right behind all the tissue. Seeing density in these areas is a major warning sign. Okay, here's a high-yield pearl for your exams, a real gem. Now, some breast asymmetry is totally normal, right? But if you're staring at a multiple-choice question about it, your brain needs to immediately jump to the shrinking breast of invasive lobular cancer. This specific kind of cancer can actually cause the breast to retract and look smaller. It's a subtle sign, but an absolutely critical one. Okay, next section. Once a cancer develops, it's going to start looking for an escape route. And that main route is what we call the lymphatic superhighway. Understanding this network is absolutely essential for staging the cancer and figuring out a patient's prognosis. And you know what? The map is surprisingly simple. Just look at this chart. A staggering 97% of the breast's lymphatic drainage goes to the axillary nodes. That's the lymph nodes in the armpit. Only a tiny little fraction, about 3%, drains to the internal mammary nodes. So for all practical purposes, the axilla is where all the action is. It's where you need to look.
Now, the axilla isn't just one big zone. We actually divide it into 3 levels. And the key landmark for telling them apart is the pectoralis minor muscle. It's that simple. Level 1 nodes are lateral to the muscle, level 2 nodes are deep to it, and level 3 nodes are medial to it. This straightforward anatomical division is the entire foundation of surgical staging.
And the flow is usually stepwise. It's a pretty orderly progression. The lymph and any cancer cells hitching a ride will typically travel from level 1, then to level 2, then up to level 3, and from there it's on into the thorax. This predictable pattern is exactly what lets us assess how far the disease has spread. So what about this potential point of confusion, Rotter nodes? You hear about them from time to time. Well, these are just lymph nodes that are located in between the pectoralis major and minor muscles. And the key thing to remember is that for staging, they are simply considered level 2 nodes. That's it. And here's a funny bit of trivia from the source that might help you remember that.
Because the name Rotter sounds German, it's considered less likely to be a big focus on exams compared to all those French-sounding eponyms. A strange, but hey, maybe useful mnemonic.
All right, let's get to our final section. We're going to talk about anatomy's ant minis. These are normal variants that can look like something sinister, and they're pretty much designed to trip you up on an exam or even in the reading room if you're not careful. So imagine you're looking at a mammogram and you see this weird-looking thing medially. The first reaction for a lot of people is, what on earth is that? I mean, it kind of looks like a mass, but it's actually one of the most classic anatomical mimics you will ever see.
This is the absolute definition of an ant mini. It's a finding that is so classic, so unmistakable, that once you've seen it, you should recognize it instantly, just like you'd recognize your own ant mini from across a crowded room. And our mystery finding is a perfect example. It's the sternalis muscle. It's just a non-functional muscle that sits next to the sternum that about 5% of people have.
So how do you nail the diagnosis and not get faked out? Here it is, the single most important, most testable fact about the sternalis muscle. You will only see it on the CC, or craniocaudal view. It completely disappears on the MLO, or mediolateral oblique view. So if you see a medial mass on the CC that's just gone on the MLO, congratulations, you found your Aunt Minnie.
So let's do a super quick recap of the most critical points. First, new nipple changes are a huge red flag. Second, the TDLU in the upper outer quadrant is ground zero for most breast cancers. Third, the pectoralis minor muscle is your key landmark for defining those axillary lymph node levels. And finally, the sternalis muscle is the classic Aunt Minnie, a normal variant you'll see only on the CC view.
So we've covered the major landmarks, the danger zones, and the classic decoys. And that leaves us with one final thought. Now that you can spot the obvious fakes, what truly subtle sign of early disease might you be looking for next on your imaging?